it is astonishing to see how low the implementation rate is. So again, only 15% of eligible Americans undergo lung cancer screening, and among those screened, only 40 to 50% return annually. So therefore, only a small fraction of the population receive the full benefit of screening. Why screening matters? We have more than 238,000 lung cancers annually in United States and 1.8 million globally. And unfortunately, most cases are detected in advanced stage. So there is a need for a lung cancer screening, and we know that staging has an impact for prognosis. We have known that for many years. So it has been big randomized studies which led to screening criteria. This was the criteria made in 2013 by the U.S. Prevention Task Force, and the criteria was age determined, 55 to 80, more than 30 pack years, and they should have quit within 15 studies that you reduce lung cancer mortality with more than 20%, and even more for women. Then they have changed criteria in 2021, and as you can see, the age has gone down to 50. Now it is 20 pack years, but still not much movement, though. Although there is certainly an expansion of lung cancer screening eligibility based on the new criteria. So younger patients to 50 and above, and 20 pack years. The problem with lung cancer is that we see more and more lung cancer in never smokers. We see more and more lung cancer in younger patients, and they are not included in the current screening criteria. And that is certainly a problem. The issue is not whether these cancers are curable. They are. Early stage disease, lung cancer, are curable, but the issue is whether society choose to look for them, and that is related to the screening uptake. The screening uptake in America is 15, at best 15 percent of eligible population. That is very, very low compared to the benefit of lung cancer screening and compared to what we see for breast cancer. So we need to do definitely something with the penetration, implementation of lung cancer screening. The data are there. The data clearly shows how important lung cancer screening is, and it is astonishing to see how low the implementation rate is. So again, only 15% of eligible Americans undergo lung cancer screening, and among those screened, only 40 to 50% return annually. So therefore, only a small fraction of the population receive the full benefit of screening. Now, we are starting, and at Mount Sinai in New York, we have a long tradition of lung cancer screening. We are the host of the international I-ELCAP consortium, which has a really wide global reach. And we are moving more and more into not only lung cancer, low dose CT for lung cancer, but also include cardiovascular diseases in our screening program. So, lung cancer screening works. We know that current criteria capture only a part of the risk population. The question is not whether these cancers are curable. The question is whether we look for them or not. So finally, how can we do a better screening? Well, liquid biopsy, early detection is a holy grail these days. You might be familiar with the grail and other assays. The problem is um, the technology is developing, but still the sensitivity is very low. And uh, while the specificity is pretty high, the sensitivity is very low. And in the meantime, we are seeing developing multi-cancer early detection uh, assays which capture many cancers on the same time based on DNA and protein expression and other molecular characterizations. They are not yet FDA fully FDA approved in United States. But where are we going in the future? We are going in the future probably, and including AI, as we have heard about many times today, we probably need a multi-omics solution to lung cancer screening, including liquid biopsy, ctDNA, methylation, fragmentomic, proteomic, and combined with clinical data, combined with radiology assessment with low dose CT. So that is probably where we go in the future. But in the meantime, we are struggling, unfortunately, with very low implementation of lung cancer screening. Thank you very much.